Okay, so welcome. I guess this is the last session for the conference here, again, this is the debaters where perioperative physicians come to compete. Hopefully some of you will laugh, and definitely all of you will decide the winner at the end of this 15 minutes here. My name is Manoj Lalo. I'm actually an anesthesiologist at Ottawa and also associate scientist at the Ottawa Hospital Research Institute. So I've actually been given instructions to model this off of The Debaters, which is a CBC show. However, I'm not really funny like Steve Patterson, and I'll certainly keep the punny jokes to a minimum, as I suffer from irony deficiency. Ooh, yes. So for this debate, we have the following. Be it resolved that remote automated non-invasive monitors represent the next major paradigm change in perioperative medicine. But first I'll briefly introduce the combatants. From McMaster University, he's a professor, Department of Medicine, Department of Health Research, Methods, Evidence, and Impact. He survived his first debate, I guess, on Friday, and he's back for more now. It's PJ, the Dawn of Remote Monitoring, Devereaux. And in this corner, also from McMaster, he's an assistant professor, Division of General Internal Medicine, Department of Medicine. Here's John, just say no to remote monitoring Neary. So, PJ, you're going to start this. You have 2 minutes, which begins right now.
Is this picture familiar to you? You walk into an ward, 11 a.m., any surgical ward. You go in to see this patient. You turn on the lights. You go over. You lift up the curtains. You sort of move a bit away the cobwebs, and you look under and you think, Mrs. Smith, you don't look well. You measure her blood pressure. It's 70 on 40. Her heart rate's 125. Her SATs are 85. Has anyone ever had this encounter? This encounter should not happen. It happens on our surgical floors. I'll offer you an historical perspective. 100 years ago, research pretty convincingly shows about 1 in 1,200 people died from anesthetic-related complications in the OR. Today's world, 1 in 200,000. What is one of the things that has happened? ORs today are like actual ICUs. Incredible monitoring. Now, many things result in this shift, but I will put forward to you that for certain the monitors were a big part of this shift. And then the problem is we send people back to the floor, and it's like Darwinism, survival of the fittest. And the reality is on surgical floors in our research, you are exceptionally lucky if your hemodynamics are checked every 4 hours. Realistically, it's every 6 hours, and not infrequently, it's every 8 hours. And we're magically hoping the nurse happens to arrive and our patient on narcotics, post-anesthetic, 5 minutes before they deteriorate. That does not happen. We need to move into a world where, in fact, we have monitors on patients that remotely are monitoring their blood pressure, their heart rate, their SATs, their heart rhythm, and actually alerting nurses continuously to this to allow us to respond in a timely fashion, as has allowed for the advances in the intraoperative setting.
Okay, thank you, PJ. So now here to argue that remote monitoring is the next Titanic in waiting is John Neary.
Thank you, Manoj. What PJ's arguing here is that we should be screening asymptomatic patients with continuous remote monitoring and that this will improve outcomes. If we're going to talk about a screening test improving outcomes, it's not enough to show that the test detects disease. It's not enough to show that the test detects disease early. It's not even enough if you know that there's an intervention that treats that disease. What you need to know is that this screening test is going to improve patient outcomes by leading to intervention earlier in a way that's going to make a difference. And right now, we don't know that about non-invasive monitoring. Let me give an example to make this concrete. Right now in South Korea, practically every 30-year-old person in South Korea is going for screening thyroid ultrasonography to look for thyroid cancer. Ultrasonography is great at picking up thyroid cancer. It picks it up early. Thyroidectomy prevents death from thyroid cancer. What are the outcomes in South Korea? They have just as much advanced thyroid cancer as we do and just as much mortality. Why? Because the screening test, even though it detects disease, doesn't make people better. Why are they doing it and we're not? Because they bought the hype and we didn't. So before we do something like this, we need to know that it actually works. An example closer to what PJ's talking about is continuous external fetal monitoring in normal labor. Increases operative vaginal delivery, increases C-sections, doesn't prevent perinatal fetal morbidity and mortality, doesn't improve long-term outcomes. PJ's right that anesthesia has made incredible gains for patients. In fact, I would say all the important gains in perioperative care are things that anesthesiologists and surgeons do. General
He's appealing to the moderator on this point.
General anesthesia,
Keep talking,
general
yes.
anesthesia, perioperative antibiotics. He's right that monitoring in the OR and the ICU makes people better. That's because there's a friggin' anesthesiologist standing right over your head taking care of just you. We're talking about an ortho ward with an RPN taking care of 12 patients and a surgeon who's running clinic 5 miles away. No, we're going to find data and it's not going to make anyone better.
Okay. To the second, wow. So next we have the bare knuckle round. So it's each of our debaters have some time to rack up some extra points here. Might get a little bit nasty, just like Donald Trump on a Twitter rant right now. So
I want to know how
John will
PJ's
start.
even going to sell this to the cardiologist. Because he's going to be putting these monitors on people, and who's going to be responding to them? You think ortho's going to be making this better? No. Ortho's in the trauma room dealing with stuff that they need to fix. So who's this going to come to? It's going to come to cardiology at 4 a.m. Mrs. Jones had 2 beats of VT.
You know how I learned about John accepting to do this debate? I'm leaving my office one day, walk out to the car parking lot, a pigeon lands on my car with a piece of paper on the bottom. PJ, I agree to debate you. John, get with reality. This technology is not the enemy. There's bugs to work out, but good God, get a cell phone, get a monitor on the floor. Let's move forward, help these patients.
The cardiologist.
John's kryptonite is he's a great guy and he's brilliant, but he's a flower child. Come into the future, John.
The cardiologists have had a go at this before. In the 1980s, when they were monitoring post-MI patients, before we could actually do anything post-MI, when we just gathered data, everyone was on monitors, and they'd have a couple beats of VT or some ectopy, and what would happen? We'd put them on lidocaine. Or if they were really lucky, we'd put them on flecainide. Right? What happened to those people? They had less ectopy. Why? Because they were dead. So before we say we should start doing this, we need to know it's going to actually lead to something that makes people better.
If we wait for John's evidence, we will all be dead. We need some monitors.
Ladies and gentlemen, you just heard PJ Devereaux arguing that we don't need more evidence in perioperative
I'm
medicine.
not
I rest my case.
Some things are that obvious.
Okay, so I guess we'll bring the bare knuckle round to a close there. So now we have a lightning round. And as moderator, I've got a couple of questions here for each of you. Questions are in my hand here. They've been brought to you by the Ontario provincial government. Actually, scratch that. They wouldn't give a room of physicians anything, would they? So
they don't want to fund the...
Sorry, I voted Liberal, okay? I guess it's being recorded right now. So.
They don't want to deal with the electricity that the monitors will use up.
Okay, so question number 1. We need, and you guys can actually ring in, so whoever wants to answer this first. We need a good or catchy acronym or short form for perioperative remote monitoring. Well, wait. What would be a good acronym for perioperative remote monitoring? Now you can go.
Mother's milk. You can't argue against it.
I'd like to call it telemetry for remote uninterrupted monitoring perioperatively, which stands for Trump, because this is fake news.
I'll go one serious question here about today. So which group of patients do you think will benefit the most from remote monitoring?
Ones whose last names are Welch, Allen, or Phillips.
I don't know, PJ, do you have an answer for that too? Or?
Well, I mean, the obvious thing is it's not going to be the 40-year-old who's healthy, but the majority of our patients who are older, compromised, post-anesthetic, on narcotics, going to a floor, they need monitoring.
Yeah, fair enough. And last question, who invented remote monitoring?
I'm going to guess the Dalai Lama because it's so obviously good.
So in Genesis 2, after excising one of Adam's ribs, God put Adam on remote non-invasive monitoring to see if he would be compliant with his diet orders.
So
He wasn't.
Okay, so that brings the lightning round to a close. It's almost time for our audience to pick the winner, but before we close, both PJ and John will have, in this final round, 2 minutes to close their arguments, and we'll start with you, John.
Thank you, Manoj. You know, I said earlier that the history of perioperative medicine is that all the advances are made in the OR. I was asked here to speak about whether something would be the next big thing in periop medicine. That presupposes that there was a last big thing in perioperative medicine, at least outside the OR. And when you look back, it's hard to find one. The best I can think of is VTE prophylaxis. Everything else that's really important is in the OR. It's not stuff that me and PJ do. There have been a lot of trials, people looking for the next big thing.
Not stuff that you do, John. Just
and they've all flamed out. There was the CARP trial in 2004. People thought it was unethical to randomize high-risk vascular surgery patients with established coronary disease to pre-op revascularization or not. Guess what? It didn't make them any better. Then some people said, well, that's because they were all on beta blockers. The beta blockers were preventing the MIs anyway. Now, I shouldn't be the person arguing against here, because there's someone who'd be way better at arguing against the hype in perioperative medicine than me. Because after CARP, someone else set out and said, I'm going to do a big study on beta blockers and see whether this works. People thought it was unethical. He did it anyway. 8,000 patients, prevented a few MIs, caused stroke and death. It debunked the hype. Then that same person went on and said, well, what about some other interventions? Let's study aspirin. Let's study clonidine. Maybe those will make... Again, people thought you were crazy. You're randomizing people to aspirin. Of course they should be on aspirin. Guess what? Aspirin caused bleeding. Clonidine caused hypotension and cardiac arrest.
You seem to be
Neither
highlighting, John. I can
MIs.
pick actually what we should be studying and not remote monitors.
If you want someone to debunk your hype on a question periop medicine, there's one person only that you should be looking to, and that man is not standing beside me, but standing beside him. It's PJ Devereaux.
Thank you, John. So I'll let PJ close now with his 2 minutes.
Who in this room has a Fitbit or something on their wrist? Raise your hands. Okay. Do you honestly think that you're in more trouble than your patients after leaving the OR, heading back to the floor? Remarkably, the young, healthy people walking around our streets have better monitors on their wrists than we actually have on patients on surgical floors. There's a fundamental disconnect. If we can give these people monitors walking around who are happy and healthy, why would we not give a monitor to someone who is so compromised on a surgical floor? We just finished the vision study, and we just had a 2-day meeting just before this conference. And one of the things that was presented there by Jessica Spence was looking at overall mortality. 99.4% of people who die in the first 30 days after surgery die after they leave the OR. The OR is an important place, but the place that is actually where everything goes wrong is after the OR. We are fundamentally missing what is going on here, and one of the big reasons we miss it, we don't monitor people well. John is 100% right. There's a lot to get worked out with these remote automated monitors, but I actually am convinced it is the future. And I will come back to one of the things I said initially here. If there is any anesthetist or surgeon in this room who would agree to undergo surgery and say, turn off all the monitors, don't need this stuff, then you should vote for John. For all of those of you who think, I really would prefer that monitor to be on, you should be voting for me. And listen, I'm one of the Luddites in the group. If I'm advocating for this stuff, the train is leaving the station. It's time to jump on board.
You can interrupt if you want.
I can interrupt. It's an old aphorism in anesthesia that the only indispensable monitor is a skilled anesthesiologist. It's the person who matters more than the data.
I think he's appealing to me again now.
So he's going to get another 5-minute rebuttal. Here.
John, please continue.
I'll leave it there.
Okay. Okay, so that brings our debate to a close here. So by sound of applause here, I guess, who believes John just say no to remote monitoring Neary? Applause now. Okay, and by sound of applause again, who is on PJ's ship
Time to
here?
raise the roof, raise the roof. The monitors have it.
I work for him anyway. Just vote for him.
The whole thing was rigged. Okay, perfect. Thank you for your time, everyone.
Manoj.